Documentation somewhere. Can be archived.
Online 1,000.
Okay.
So you expect to have some questions?
Yes.
That's 10 minutes maybe.
The
Online.
just the questions on WhatsApp. On my level, questions on WhatsApp.
Why did you fly from?
São Paulo. No. Qatar. Doha, because there is a direct flight São Paulo. Doha. 14 hours. 14.
That's not bad. From Qatar to like 17 and a half or something.
It was really good. And then 4 hours of transit. Riyadh, it's only 1 hour.
That was number one, I think, for like 3 years in a row or something.
4 flights, 2 Emirates and 2 Qatar. Every day. To Middle East. So to
You like them?
Yeah. Quite convenient.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific session, in this wonderful place and in the holy day of Al-Jum'ah, where I pray Allah subhanahu wa ta'ala to make all the blessing in this gathering and to grant us the success to go ahead with our responsibility as a physicians to secure the best interest for our patients. And I would like to welcome you back again here to the vaccine talk that we have started many months ago. And because of the great success that we have achieved in the previous sessions, we decided to make another session which will be more, inshallah, successful than the others. And by the time we go for one version to another, definitely we'll be adding a lot of interesting items for all of you, just to address your concern, address the real practical parts that is related to our day-to-day practice. So I would like to mention that why we are here today, because definitely all of us as a physician with a special focus for primary care physicians and family physicians, they need to know and to learn more about the emerging updates in the respiratory infections and the availability of the vaccine, and to learn more about the efficacy and the safety of those vaccines in order to be competent enough and confident enough to go ahead with the proper recommendations and implementation of this important tool to safeguard our community, and with a special focus on the high-risk populations. Not only this, but also we have been challenging by a challenging change in our demographic in the Kingdom of Saudi Arabia. So we have our populations who are growing to the age above the 65 years of age. They are going to be increased in the coming years. It has been estimated that they are going to be doubled by the year 2050. Not only this, but also the chronicity of the disease. We have been identified to be one of the top 10 countries in the high prevalence of diabetes, dyslipidemia, and obesity. And all these demographic changes that has been made, and it will continue to go ahead, will subject our community to the risk of having the liability of having this disease. And the other item is that our healthcare system now, ladies and gentlemen, is moving from curative medicine into preventive medicine. So that's why we have to implement all the preventive measures. And one of the very important tool of preventions is education, number one, and the second one is vaccinations when we talk about the respiratory disease. The other things that put us a lot of responsibility on all of us is because we are a primary care physician and a family physician, we have been positioned to be the gatekeeper of the healthcare system. So we cannot afford missing a case that is eligible to have the protections of vaccines or to do some kind of intervention to prevent the disease and not to do it. So I think our responsibility is great, and by the time we have to show our competency and our commitment to our patients in terms of responsibility and accountability. So today the vaccine talk, ladies and gentlemen, came to fulfill our felt need towards our real changes that we are addressing in the season of the winter season towards respiratory disease. And today we are going to focus on the RSV virus infections and the prevention. So without any further delay, I would like to say that we have been privileged today in our discussions in the vaccine talk to have our eminent speakers who are experts in the field. And we have Dr. Arim Al-Amir, Dr. Mohammed Zaitouni, and Dr. Otavio, who are going to explore and highlight and show us certain important features that will cover the whole subject in terms of the burden in older adults and the impact of the RSV in comorbid patients and the RSV prevention guidelines. And finally, we are going to highlight the vaccine in terms of efficiency and the safety. So let's go ahead and hope that this meeting will be quite rich and fruitful for all of you. So, على بركة الله نبدأ. Slides. So I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant in family medicine. I'm the vice president of the Saudi Society for Family and Community Medicine, and I have been privileged to be the moderator for this session, which will be interactive, not only between us as speakers and moderator, but also along with you. So it will be an interactive session. I would like to say that we have Dr. Otavio. He's a regional medical affair lead, RSV, GSK vaccine emerging market, and Dr. Mohammed Zaitouni, who is a consultant and a program director, pulmonary medicine, King Faisal Specialist Hospital and Research Center in Riyadh, in the Kingdom of Saudi Arabia. And Dr. Arim Al-Amir, she's a consultant transplant infectious disease, King Faisal Specialist Hospital, and the Research Center and King Saud University in Riyadh as well. So this is our disclosures, and we are going to start now with the respiratory syncytial virus and the associated disease. So this is the first part of our session in the vaccine talk. For this, I would like just to convey the first questions that will highlight the basic information that we would like to learn about the RSV virus. So it will be directed to Dr. Arim. Dr. Arim, can you tell us about the RSV infections?
Of course. Let me see, is this working?
Excuse me?
Okay. Can you hear me now? Okay, good. I just want to say thank you so much for the invitation, and I'm really excited to talk about RSV and vaccines. This is my passion. So to start with, RSV is a highly contagious respiratory virus. Let me see, yes. So it's a highly contagious respiratory virus which usually runs in seasons or circulates in season like any other respiratory virus. The transmission is similar to other respiratory viruses where the inhalation or the contact with infected respiratory secretions might put you at risk to get RSV. As I mentioned, it's highly contagious, so it's expected that your household contact might be infected. The important thing about RSV that the shedding or the being contagious to others will last from 3 to 8 days. However, in older adults or those with weakened immune system, it may last longer because they don't have the enough immune system to control the virus. Seasonality, we know from previous studies that RSV is a seasonal virus that runs usually, especially when we're talking about the northern hemisphere, over this 5 months period, which is mainly winter time. However, in the tropical zone area or our regional area, a little bit different outbreaks will occur every now and then. We did notice during the COVID-19, especially the beginning of COVID-19, almost the disappearance of the other respiratory viruses, including RSV. But later on in 2022, 2023, we started to see like an outbreak, especially early on in the season, which is not the usual. Let's see. So there is a kind of a misconception or a myth surrounding RSV that it's a disease of the children, but actually RSV can infect any age group. Usually most of us as children, we will be exposed to RSV, but because of the natural immunity is short-lived, we're not protected and we can get RSV infection repeatedly during our lifetime. But it's important to focus that older adults are at increased risk for having severe RSV infection. So what is the signs and symptoms of RSV? It's like any other respiratory viruses. So if you're a young, healthy, otherwise adult, most probably you will present with an upper respiratory tract symptoms, which is usually mild and self-limiting. The issue is when we go into certain populations, especially the elderly and those with a weakened immune system, then they will get RSV complication and severe disease, including lower respiratory tract infection, cardiovascular events, exacerbation of underlying disease, which subsequently will lead to higher rate for hospitalization and unfortunately death.
So, Dr. Reem, what is the mode of transmission of the virus?
So it's inhalation, so it's through respiratory droplets. So if someone is infected by coughing, talking, speaking to you, he might transmit the infection.
Okay.
And it's estimated that one infected patient can transmit the infection to at least 3 other people surrounding him.
Okay, very clear. So what are the associated risks in adults, Dr. Reem?
So if we can go back to the slides, when we look into risk factors for RSV, usually we're thinking about 2 groups. It's the older adults and those with comorbidities. So older adults, we're talking about those who are older than the age of 60. In my mind, they're still young, but they're considered older adults. But then, and as well as those with comorbidities. So someone with chronic lung disease, heart failure, your complicated type 2 diabetes patients, those with CKD, as well as high risk for severe disease and complications. And we cannot forget our patients who have weakened immune system, like our solid organ transplant patients, hematological malignancies, rheumatology patients, and HIV patients as well. So when we talk about the burden of RSV in general, I don't think we have a very good national data, unfortunately. However, if we look into the international data, we can see that RSV is not a disease of the children only. Even older adults, they have a substantial number or burden of the disease, and it's specifically when it comes to higher rate of hospitalization and death in those older adults. So we have to keep in mind that actually older adults might be more likely to be admitted to the hospital and more likely to have severe complication and sequelae from the RSV vaccine. There was this systemic literature review and meta-analysis that specifically looked into the annual burden of RSV-induced acute respiratory infection. And this was done mainly in countries with high income. And they did find, to my surprise, to be honest, that around 5 million patients will get RSV respiratory infection that will end up in hospitalization in around 500,000 of them, and around 7% fatality rate, which is considerably huge.
Okay, Dr. Reem, it was very clear what you have said, but what about the risk and morbidity and mortality of RSV when we compare it with the influenza?
Of course, so basically we always think about influenza as the bad guy, but I think RSV should be considered a worse guy, maybe. Yeah. So even during our training as healthcare workers, we always hear about influenza, and sometimes even we underestimate influenza. But no one ever talks about RSV and how severe RSV can be. So there is lots of prospective studies out there that looked into the outcome of influenza versus RSV in older adults. This is one of them. This is one example. And as you can see, RSV did almost comparable to influenza and even sometimes even worse. So if you get RSV, you're more likely to have pneumonia, and we're talking specifically about older adults. You're more likely to get secondary bacterial infection, cardiac events, and probably more likely to die.
Yes.
So the other part when we talk about older adults is how infections impact their quality of life and their functional status. This is a very important topic that sometimes we miss to talk about. And we know from previous studies, from infection point of view and other things, that older adults, when they get an infection, they do lose their their independence and functionality. And that was studied in RSV, and there was like an estimation of around 8% of those patients who are admitted with RSV, they will lose their functional independence for almost 6 months. And why do we care? Because patients who are older adults and lose their independence, they're more likely to be dependent on the health system. So this is an economic burden. Plus, they are more likely to fall, more likely to go back to the hospital with admissions, and unfortunately, they're more likely to die after their RSV infection within the first year.
Okay. So now I think Dr. Reem has illustrated very well the RSV, the burden in older adults, and the impact of RSV in comorbidities and comorbid patients. So now I think we will move to another part, which is another interesting part, which is the RSV and the cardiorespiratory conditions, which is the two important conditions that has to be considered as a risk for those patients. So my question for Dr. Mohammed Zaitouni, as a pulmonologist, what are the common comorbidities associated with the RSV?
All right. Thanks, JSK. Thank Dr. Hoja for the nice introduction. Obviously, as already mentioned, RSV is a respiratory illness that affects all ages, but the main problem is in the very young, but also in the older population, middle age, and they're 60 and above, especially those with a comorbid condition. It's compared to influenza, and sometimes it's even worse. But the bad news is we don't have a treatment for RSV, while influenza we have antiviral. For even COVID, we have medications. RSV so far plain symptomatic treatment. So if the patient, an older person gets RSV, the only thing we can offer is symptomatic and treatment, which sometimes when they're quite ill, old, multiple comorbidities, they might not do as well. Now looking at patients, the study looked at all patients above 60 years of age who were admitted to the hospital with RSV, so the illness must have been moderate to severe to require admission, and looking what kind of comorbidities they had. And we noticed that there's clustering of comorbidities among these patients. So heart failure and diabetes accounted for almost 40% of the patients had these. COPD was in one third of the patients. Ischemic heart disease in 1/3 as well. Asthma also was overrepresented. Almost 30% of patients who had respiratory tract infection with RSV that required admission to the hospital had asthma. Other illnesses such as tumors and dementia also accounted for the rest. Now, we have also other studies that looked into the association between comorbidities and RSV in people who are older. And the two studies were done, one in Scotland, one in Denmark, looking at patients who were 45 years old and above, who were also had lower respiratory tract infection, and looking at the comorbidities that they had, and presence of each comorbidity was compared to patients who did not require admission. And we notice again that you have multiple times the chance, if somebody has a COPD, like 4 to 5 times the chance of being admitted with lower respiratory tract infection with RSV than those who did not have COPD. Asthma was 2 to 4, maybe ischemic heart disease, stroke, diabetes, all these multiplied the risk for admission, meaning the severity of the illness multiple times, chronic kidney disease and chronic liver disease as well. But if we look at the most important two factors, our comorbidities that made patients several times more likely, 6 to 8 times likely, to 9 times likely, this is mainly the COPDers and the chronic kidney disease patients. But also, the older the person gets, the more likely they will actually be to have severe infection that require hospitalization. So these two studies looked at patients who are 45 years age and above. Once people reach 65 years of age and more, then they had much more chance of being admitted, and definitely those cohort above age 85 years had the highest chance of being admitted with severe RSV. Also, patients with COPD and asthma, again, looking at these patients, also the older they get, the more likely they will be admitted with RSV. If they acquire RSV, 6 times the chance of younger people less than 75 years of age with RSV infection. So very important to take into account the age of the patient, but also the comorbidities that they carry.
Okay. All right. Thank you, Dr. Mohammed. Now we'll move towards Dr. Mohammed highlighted the respiratory conditions and the comorbidities in terms of respiratory, cardiac, and even the chronic kidney disease, which increase the hospitalization for those people who are above the age of 65 years. So now we'll move towards the RSV and the respiratory conditions. And the question is again for you, Dr. Mohammed. As a pulmonologist, could you take us through the RSV and the chronic respiratory conditions?
Sure. So, respiratory conditions are, the non-communicable diseases that rank among the highest in prevalence. So, if you look at COPD patients or COPD in general, it is the 3rd leading cause of death worldwide. It affects probably 250 to 500 million people worldwide. And unfortunately, especially in our part of the world, for 3rd world countries, the prevalence is on the rise with, unfortunately, the more people acquiring the habit of smoking in all its forms and shapes. So it's not only cigarettes, all kinds of tobacco, unfortunately. Asthma, again, is a very common illness. It is commoner, obviously, in younger people, but also affects all age groups. It is, can also lead to significant morbidity and mortality. And again, the prevalence is increasing. Many people think it might have to do with the Western lifestyle, the processed foods, the carpeting, the pollution, but fact on the ground is asthma is also becoming more prevalent and overall in the world and in our population in specific. Both asthma and COPD, life journey of the patients are interrupted by occasional sudden worsening of their symptoms, requiring intensifying of their treatment, requiring visits to emergency rooms. If severe enough, many of these patients are admitted. These events are called exacerbations, so COPD exacerbation or asthma exacerbation. And there are many factors that account for these exacerbations, including allergen exposure, air pollution, bacterial infections, seasonal changes, and definitely poor adherence to treatment accounts for some of these exacerbations. However, respiratory viruses remain the most common cause for exacerbations. Among asthmatics, 60 to 80% of the asthma attacks or exacerbations are related to viral infection. And COPDers, it's anywhere between 22 to 64% of exacerbations, which are not uncommon events in COPD that drive healthcare costs and drive admissions and mortality, again, are related to respiratory viruses. So if we look at the effect of respiratory viruses in patients with, say, COPD on your left-hand side and in orange color, you find that having obviously a viral infection will increase the inflammation in the airway. Definitely patients with a viral infection compared to those with COPD, they have higher, when tested, they have more intense hypoxemia. The respiratory function decline, which happens with exacerbations, tends to be much more severe, double that of that patient, those patients who had non-viral infection as the cause of their exacerbation. And definitely looking at the hospital stay, for all comers with exacerbation of COPD, we notice that patients with non-virally induced exacerbation, their average length of stay is around 9 days compared to 12 days, 1/3 more stay in the hospitals if they happen to have a viral infection. Similarly, in asthma, we have in asthmatics, as you know, their immune response is geared toward more the allergic side. So what we call Th2 response, T helper 2 response, less Th1 response, so less interferon. So again, these patients with asthma tend to not tolerate respiratory viruses well because of this, and they end up having exacerbations, which, as I mentioned already, most of the exacerbations in asthma are related to viral infections. And if we look at patients, general asthmatics, if they are exposed to an allergen, they might have a 10% chance of exacerbating, but if they happen to have a viral infection, and on top of it, they get exposed to an allergen, they have 8 times the chance of having an exacerbation. And a fact on the ground is, out of all asthma exacerbations, you're all practicing seeing patients with asthma, tons of patients having exacerbations, 7.2% of all the exacerbations are related to RSV infection itself, not overall respiratory virus, but RSV alone accounts for 7.2% of the total asthma exacerbations, a huge number. So if we look in terms of asthma and COPD, for COPDers, 11.4% of all exacerbations in COPD are related to RSV, while it is 7.2% of exacerbations requiring hospitalization for asthma are related to RSV. Looking at another study on the right-hand side of RSV and COPD exacerbations or viral illnesses in general, we find that viral illnesses, again, are very important drivers of exacerbations of respiratory patients, especially older people with COPD, where 15% of those exacerbations are driven by the common cold viruses, the rhino and enterovirus. RSV accounts for 10 to 11% of the COPD exacerbations, and influenza, already mentioned earlier, accounts for 8%. So definitely RSV ranks among the top causes among viruses for exacerbations of both asthma and COPD. Finally, for some patients, especially older, less immunity, multi-comorbidities, some patients with COPD, when they acquire RSV, they continue shedding RSV and they don't clear it. So looking at patients who had an exacerbation with RSV and never cleared it versus those who did clear it, and we again find that the loss of lung function, the FEV1 decline over 2 years in this study was faster with patients who consistently were still shedding the RSV virus.
Thank you, Dr. Mohammed. I think in your presentations you have highlighted the most important part, where RSV virus is precipitate acute attack of exacerbation of bronchial asthma and COPD, and one of the major components for hospitalization of those people of COPD and bronchial asthma. So now we have covered the pulmonary part, but now we will go to the cardiovascular conditions that is associated with RSV. So I think this is, as a cardiologist or as an expert in cardiovascular conditions, Dr. Ottavio, what is the role of the cardiovascular conditions on RSV and vice versa?
Thank you. So I think it's here I really need to start disclosing. So for you that I started my career a long time ago looking into RSV in children. And I was talking with Dr. Ian in the beginning, so we managed to demonstrate that it's important, and now you saw the graph, so the disease is important in children, but also it's important in older adults. And we learned that children with some conditions, they are at higher risk for severe disease. And so older adults, it's exactly the same as we heard from Dr. Zaitouni, and we're gonna hear today about the cardiovascular condition. And maybe I will share with you one personal example. My mom, she's 94 years old, and she has a heart failure. And last year, she started with a mild cold, with a runny nose, nothing else. And suddenly, she started with hypoxemia and with a very intense decompensation of the heart failure. And everything was caused by RSV. So sometimes you learn the things in a hard way. So sometimes you can think, oh, it's only one case. It's really true. It happens for patients with cardiovascular conditions, and this is what I'm gonna show to you right now. So we know that those patients with cardiovascular disease, they have a high risk for many different things because their functional reserve is diminished because of the heart failure, because of the other chronic conditions, so mainly with coronary conditions. So they have really, or maybe arrhythmias, so they have a high-risk condition for severe disease associated with severe disease. And when you have a virus like RSV, that's a virus that is a virus that promotes a lot of inflammation, and they can trigger some, I would say, cardiovascular events, or it can overload a heart condition that is already compromised by a heart failure. So let's see some data showing that if it's really true. This is a small study from Canada, so it's a number of the patients are really not that big, so it's roughly 60 patients. So you see that their age, so 74 years old, and you look into the graph, the number of complications. So you see exactly what I shared with you, my personal example. So heart failure exacerbation in 14% of the patients, a new arrhythmia, so atrial fibrillation or other arrhythmia that happened after our RSV condition, and also other cardiovascular complications like myocardial infarction and stroke because of the activation of the inflammation pathway that we learned with a lot of viruses. So I think it's RSV, it's only one more, and I think like Dr. Rin said, so we can really compare with influenza, and I'm gonna show to you some data related to this. This is exactly what I saw. Now you see that the number of patients are significantly higher, so it's looking here only in myocardial infarction, also in Canada, and you look into prior to the myocardial infarction, what happened, what was the trigger, and you see that influenza and RSV is quite significant, and when you look into the virus in terms of percentage, you see that it's quite similar. So those viruses, they are really responsible to trigger this inflammation pathway that leads to a new myocardial infarction in patients at risk. And when you look specifically when we talk about heart failure, and this is another study, this study is from US, it's a huge, and you see that the number of patients are quite more significant. You see that if you have a patient with heart failure compared to a patient without a heart failure, the rate of hospitalization is higher in patients with heart failure, and also it's also related to the age of the patient. So the patients older than 65, you see that they have 4 times more risk of hospitalizations. If you really look in the overall population, so it's 8 times higher, the hospitalization rates for those patients. So you see that these data, even though it's data from US, but I talked to you about one personal example, that is an example in Brazil, you see that the epidemiology is not different. So if I look into this data in many different countries all over the world, I see the similar picture. So during the RSV season, you see more hospitalizations in patients with heart conditions.
So the RSV diagnosis and the management, and this is another important part for our discussion today. So we'll move towards the questions will be for Dr. Arim. As an infectious disease consultant, how do you diagnose and manage RSV? Especially we are in a season where we have multiple viruses like influenza, COVID, RSVs, and common cold. Right. So it's very difficult for us to find out which one is which. So what are the tools that you rely on to diagnose?
That's a very important question. So as a healthcare worker, we depend on our diagnostics for diagnosing respiratory infections. So it's the patient presenting with symptoms. However, when it comes to respiratory viruses, this is very non-specific. Most of the respiratory viruses between common cold to COVID, they have the same presentation. It's really hard to know which one you're dealing with without proper testing. And our main problem, I think, in the region and in the area, and maybe even internationally, that we don't test enough for RSV. And if you ask a primary care physician how common RSV is, and this is from national survey, they will tell you that RSV is not that common, and actually it's less than 50%, which is not quite true. And by testing and diagnosing RSV, you're doing lots of things, lots of services to your patient and to the community. First of all, you're identifying infected patients and you're isolating them so you're not spreading the infection. You're providing early supportive care for those patients who are infected and trying to improve or reduce the inappropriate use of antibiotics. So testing is key when it comes to respiratory viruses in general and RSV in specific. So again, diagnosis and early diagnosis, let's say, is very important when it comes to RSV. We were just talking in Dr. Ottavia about the fact that RSV, once it crosses and goes from upper respiratory tract infection to lower respiratory tract infection, then probably the damage is done and you have very limited things you can do to help your patient. So early diagnosis is key. And then the other key in any respiratory virus is prevention. So when it comes to prevention, before the vaccine, we didn't have lots of tools to help to reduce the rate of RSV, except, social distancing, masking, and these methods that does not really work very well. So vaccination now is a very important tool that we should push our patients and try to remember to give them the vaccine. Again, as Dr. Zaitouni mentioned, Dr. Ottavia as well, we don't have a great antiviral that fight RSV. So this is why key is prevention. All you can do for your patient is supportive care, taking care of their fever, their muscle pain. You can give them bronchodilators and whatnot, but there is nothing specific against RSV. And the antivirals that we have, they work, and maybe they don't work very well, but we use them only for specific patient population.
Okay, so coming to the part regarding the vaccine, I would like to ask you, Dr. Zaitouni, could you tell us about the prevention strategies for RSV prevention?
Thank you. If I may, just to follow on what Dr. Rahim mentioned, there's a local study from National Guard Hospital here where patients who were admitted with RSV infection and who one-fourth of them required ICU stay, and among these, one-third actually died. So when she says symptomatic treatment, yes, maybe it sounds easy, but it's very frustrating for you as a physician to see your patient deteriorating in front of you. You know the diagnosis, and there's nothing you can do about it. And you wish that, this older person with comorbidities, somebody had something to do to prevent this. So definitely the prevention is, an ounce prevention is worth a pound of cure, or more important than a pound of cure, I guess. So we need to have a vaccine, and the current vaccine we're discussing, the GSK RSV vaccine, is a combination of RSV pre-fusion glycoprotein that will induce, hopefully, some response. It has 120 micrograms, and an adjuvant, which I think happens to be the same adjuvant in the herpes zoster vaccine, AS01B, which is designed to boost the immune response even further and to become even higher as an immune response and longer lasting. So the vaccine contains on the left-hand side the antigen, which is a glycoprotein that is responsible for the fusion of the virus to the human cell, and then the virus gains entry into the cell. So if we can neutralize this protein before it reaches the cells, then hopefully we can actually break this attack from the virus and then prevent the illness. And in the worst case scenario, prevent severe illness, which is more important as well. Adding the adjuvant will actually potentiate the immune response and add to it the cellular element as well, where the CD4 cells will actually orchestrate more of a long-lasting response, and the B cells to produce antibodies. So we have the humoral response, very important, neutralizing antibodies against this pre-fusion glycoprotein that will prevent the viral entry to the cells and increase the, we know that people who have lower antibody titers are more prone to develop the virus and the infection and to actually have severe infection. And that's probably why older people end up having more severe infection, not because they're older and sicker, but because their titers of antibodies to this virus are much lower, allowing more intense infection by the virus. By the way, all of us, we get the virus maybe every few years. Unfortunately, our immunity is not long-lasting. So even after natural infection, we will have antibodies that will protect us probably 2 or 3 years or so. And then we, again, with the waning of the antibody response, we get more of virus. And especially in older people, because they actually, even with an infection, might not even develop enough antibodies. Also with vaccination, there's very important role for adjuvant to boost the cellular immune response, both the CD4 cells that support the antibody production, but also the CD8 cells that will help clear the virus out of the body. So as we get older, there's a phenomenon, all our organs get older, unfortunately, including the immune system. And this aging process, this senescence, is both in quantity and quality. So not only we have less immune cells, but we also we have less functional immune cells. And as such, we are more prone to infections. Our also cellular response and the human response both will be down, declining with age. So this is a double-edged sword. Not only we get more infections, but also we are less likely to respond to immunization. That has to be taken into account when designing a vaccine. On the right-hand side is a study looking at the titers of CD4 T helper cells against the RSV pre-fusion protein. And as you can see, compared to younger adults, older adults had 1/4 the titer. So definitely prone to having infections.
I would like just to encourage our colleagues who are attending with us online to put their questions in the Q&A box, so I'll be able to give the questions to the appropriate speaker to answer at the end of the session. So now, Dr. Ottavio, the question is for you. How did GSK run the clinical trials on RSV vaccine? It's another area we would like to learn more about it.
Thank you, and thank you for the introduction, Dr. Zeitouni. So why this vaccine has this composition with the antigen, and the adjuvant is really to overcome what we call the age-related decline of immunity. And you saw that in the graph that Dr. Zeitouni showed to us, that the plain vaccine without the adjuvant, the cellular immune response is quite lower in older adults. And we learned that we need a cellular immune response mainly to clear the virus if the patient is infected. So this is why it's so important to have this orchestrated immune response, humoral and cellular immune response. So I'm going to talk to you and over the time about our pivotal clinical trial that we call RSV 006. It's a study to demonstrate the efficacy in patients over 60 about the vaccine. So RSV in different parts of the world, they have some seasonalities. This is why I'm going to talk to you season 1, season 2 data, but I would say it's over years. So sometimes in other countries, if you look into the Northern Hemisphere, the seasonality is not so clear, but this is why I use this season thing. Just first look into the trial design. So it's a little bit complex, but I will walk through this slide with you so you're going to understand. Basically, it's a study, it's a classical vaccine study, so it's compare intervention, that is vaccination, against placebo. So this is the data, what we call the first season or the first year after vaccination. It's a follow-up roughly in 7 months. So this is the first episode, so the first box that you see here. But then we decided in the follow-up to the vaccinated arm, we decided to half of this group remain with only 1 dose of the vaccine, and a small group, so 50% of the vaccinated group, we decided to give one additional dose of the vaccine to understand if we need an annual vaccination or not, and the placebo group remained the same. So when I'm going to show you this, what we call the season 2 data, it includes these two things. So exploring if we need an annual vaccination or if you don't need an annual vaccination. And then at the end, you see that there more data will come with a 3-year follow-up or three-season follow-up, okay? And the primary endpoint of this study was to demonstrate the efficacy of prevention of lower respiratory tract disease associated with RSV. So we discussed a lot about the risk patients. So just briefly show you that in this study, we managed to include in the placebo and in the vaccinated arm different age groups and also patients with comorbidities. And also we explore, because we know that patients over 60, they have sometimes a frail index. Here, the frail index was determined by the ability to walk over time. So we managed to include all those patients to try to understand if there is differences in the efficacy in different groups. So roughly 40% of the patients included in the study, they have at least one comorbidity of interest. Since we are talking about cardiovascular, cardiorespiratory, so just to show you one example here, so roughly 20% of the patients in each group, the vaccinated arm and the placebo arm, they have at least one cardiorespiratory condition, so named COPD, asthma, chronic or respiratory conditions, and also chronic heart failure, as I mentioned to you. And briefly, of course, RSV, it's a complex infection. It starts with an upper respiratory disease and goes down to the lung with a lower respiratory tract disease that could be mild or could be severe. So this is why we use these case definitions. So just to show, and basically in the acute respiratory infections is more focused in the upper respiratory symptoms. When you go to the lower respiratory tract disease, you really need to have lower respiratory tract symptoms, and in the severe, if you really need additional support for those patients. So it's basic, it's more easy, the definition when you look into acute respiratory, lower respiratory, and severe respiratory disease. Let's show the data, the efficacy data. So just for you to know, this study was run during the COVID pandemic, so the number of cases with RSV was not as high as expected, but even though we saw here clearly the efficacy of the vaccine. In the middle is the primary endpoint, so the efficacy of the vaccine in preventing lower respiratory tract disease, and the efficacy was 82.2%, and you see the numbers, so 40 cases in the placebo group compared to 7 cases in the vaccinated group. Secondary endpoints here, you see the acute respiratory infection, 71%. When you go to the severe lower respiratory tract disease, it goes up to 94%. And you're gonna see it in the different slides that I'm gonna show you, that the highest severity of the disease, or the highest risk of the patient, the vaccine performed better in terms of efficacy when you compare to the primary endpoint. And this is what I'm showing here. So now it's the breakdown. Remember that we include the patients pre-frail, patients 60 to 69, 70 to 79, including patients over 80. And we included patients with cardiovascular or comorbidity conditions. So here you see the breakdown with 1 comorbidity and 2 comorbidities, and you see that the efficacy remained quite significant, so over 90% in the different groups of the population. So in the patients that they needed most the prevention of the disease. And when you look now specifically to the comorbidity, so if you look here, like remember that I show with at least 1 comorbidity, now it's the breakdown. Cardiorespiratory condition, 92%, in patients with endocrinometabolic condition, it's 100%, and patients with at least 2 comorbidities is 92%. So this is really a data that I'm showing you very quickly, but this data is published specific, so they have the publication with the pivotal study, but also the publication only related to patients with comorbidity conditions. One thing that I think, I don't know if you remember that Dr. Rin showed you that we have two different subgroups of RSV, A and B, but this difference between these two groups is related to the G protein and not the F protein. So this is why we decided to include only one, it's F protein, it's the subgroup A, but because there is no difference between these two subgroups. And when you see here, we demonstrated efficacy against RSV-A and RSV-B, acute respiratory infections, and lower respiratory tract disease. And it's important to show that during this specific season, the circulation of RSV-B was 2/3 compared to the RSV-A. Finally, before moving to the second season, just to show you the safety profile of the vaccine. So you see here in the local reactions, you see a little bit more of a pain, but it's a pain that it's a low grade, it's not grade 3, usually resolves in 4 days, 48 hours, so 1 or 2 days. And when you look into the systemic reactions, you see that there is some complaining about fatigue and headache, but also resolved in no more than 1 day. And when you look into the severe adverse events, fatal adverse events, or what we call immunomediated disease, you see that there is no difference between the two groups. When you look into the unsolicited severe adverse events, it's here represented the more complaint of the local reactions. So moving to what we call the second season of this vaccine. So this is the first season of the vaccine, so it's a summary. You see here 71% of prevention of acute respiratory infections, 82% prevention of lower respiratory tract disease. When you go to patients with comorbidity, it goes to 94.6%. When you go to severe lower respiratory tract disease, is 94%. So this is the first season, usually 7 months follow-up after the vaccination. When we go to a second year after the vaccination, you see that the efficacy remains high, so comparable to the first year. So you see that for the acute respiratory infection is 52%. When you go to the lower respiratory tract disease is 67. When you go to the lower respiratory tract disease in patients with comorbidity is 66. And when you go to severe is 78. So this is why this vaccine offers protection over 2 seasons, and here you are seeing 20 months of follow-up after the vaccination. So you don't need to wait, or you don't need to vaccinate these patients every year. By the way, remember that in the clinical trial, a small portion of the patients received a second dose after 1 year, and this second dose did not increase the efficacy. The efficacy is the same, so definitely this is a vaccine that you don't need to vaccinate every year. So if you go to a final summary about the vaccine, so the trials, so this study, that it was a study designed at placebo against vaccination, the efficacy was 82% for lower respiratory tract disease, 94% for severe lower respiratory tract disease, 94.6% in patients with at least one comorbidity, and 93% in patients 70 to 79. So one dose demonstrated this over 2 seasons, and as I said to you, revaccination was after 1 year did not increase the efficacy compared to the patients that received only 1 dose. And the vaccine demonstrated an acceptable safety profile, as I demonstrated to you, only with the local reactions that resolves usually in 1 or 2 days.
So the immunity, Dr. Ottavio, just lasts for 2 seasons. What's next?
What's next is the third season. This data will come soon, very soon. The data will be released.
All right. So what is the best timing to vaccinate at-risk populations in terms of the season?
Yeah, this is a very important question. So since we do not have, we don't need to wait for the season, so my understanding is that you can vaccinate the patient anytime, okay? You don't need to wait the season. It's different if you compare to other vaccines that you need to wait for the season, but it's more related to the vaccine composition. Here, no, quite stable virus that we demonstrated the efficacy over 2 seasons, so you don't need to wait the season. Sometimes people remember more to vaccinate close to the season, but here you don't need to wait the season to vaccinate.
Okay, thank you so much. Dr. Reem, another question which is very practical, the co-administrations of the vaccines and in the upcoming flu season, what is your recommendations?
It's a great question because we always get this question even from patients. Is it more harmful to get 2 vaccines at the same time? And I think we do have data that, I'm not sure if this is moving. Is it moving? So there is open label, multi-country randomized clinical trial, actually 3 of them, that looked into this specific point, which is the co-administration of the RSV vaccine with quadrivalent influenza vaccine. And they looked mainly into the immunogenicity and the side effects or the safety profile of the co-administration. And this is the details, I think, of the study. So basically, they randomized the patient to either take simultaneously both vaccines at the first visit, and then they will follow them up at day 31 and 61 to see the immunogenicity level and the safety profile, or they were given 2 vaccines separately, at least 1 month apart, and then again they looked into the immunogenicity and the safety profile. And the primary endpoint, as I mentioned, was the non-inferiority of the co-administration versus 1 vaccine each time, and the secondary endpoint was the reactogenicity and the safety, and of course the humoral immunogenicity. And from the conclusion from all these 3 trials, the immunogenicity was not affected of either vaccine, and most of the patients tolerated both vaccines very well with no aggressive or like severe side effects. And I think it is safe to go ahead and give both vaccines at the same time.
I think this is a very important point because understanding the behavior of our people, especially the other adult, they comes and they disappear. So I think it's a missed opportunity for us if we don't co-administer as much as we can of vaccine that is required for those people. So this kind of missed opportunity should not be, it should be tackled, in order to optimize our precious encounter with patient at that particular moment.
Right.
Okay. We'll talk about the RSV vaccination licensures and the recommendations. And for this, Dr. Zeitouni, can you tell us about the current global recommendations of RSV older adults vaccines? And then we will come to the local recommendations if it's available by the other speakers as well.
All right, thank you. So I want to start by saying we are lucky here in Saudi Arabia and Emirates in the Gulf to be one of the first countries where the vaccine is introduced among, here, as you can see from this map, around 18 countries.
I think we are the fifth country.
We're the fifth, but yes. But among, but so it's really now limited to certain countries. So we're quite lucky to get it quite early. But it's been approved definitely in Europe, European Union, in US and Northern America and Southern America. The guidelines, both the GINA guidelines, Global Initiative Against Asthma, and the GOLD guidelines for the Global Initiative for Obstructive Lung Diseases, both recommend that patients with asthma or with COPD, respectively, should get RSV vaccination. What is even more impressive is that the GOLD guidelines and their recommendation for vaccines list RSV as the only vaccine with evidence level A for vaccinating patients with COPD. Influenza, other vaccinations, level B. So definitely the proof is there. Very important to vaccinate these patients. They're, in general, COPD, they're older, they're frailer, so much more important to follow the policy, I say buy one, get one free, you get influenza at the same time, you get the RSV as well.
Okay, I would like all the audience, virtually and physically attending, just to scan the QR code, because there is two important questions. One is a revision of all the information that we have highlighted in this presentation, and then to evaluate the quality of information and the setup of this scientific meeting. So I think this comes to the conclusion that we have highlighted all the issues that is related to RSV virus and infection. And I would like to open the floor now for the questions. Okay, just keep
Go
the
back.
QR code.
Yeah, you can go back.
Go back.
Yeah. Yeah.
Okay.
That's right.
I'll give you 5 minutes to have the scan and then to answer the question.
So till they are doing this, I just have a small comment on Dr. Otavio's presentation. I mean, it is really the lower respiratory tract infection that what matters the most for us as physicians. And the severe one as well. So even the second season, although the overall it was in the upper 50s, but the severe lower respiratory tract infection prevention was close to 80%, which is the most important. Same thing with the COVID vaccination. It's not to prevent, the idea of the vaccine is not to prevent infection as much as to prevent severe infection,
Right.
which leads to hospitalization, to problems, and to mortality.
No, I think this is a very important point. So this, because the upper respiratory infection is maybe not so harm for the patient, so this is why it's important to prevent and to prevent the progression, because we learned that RSV, it's clear it's a progression. So it starts in the nose and goes down to the lungs. So you really need to keep it in the upper or avoid the infection. So in the first season, so we demonstrated to prevent infection. It was even, I would say, significant. It remains significant in the second season, but as Dr. Zaitouni mentioned, so what is really important is to prevent the lower respiratory tract disease.
Correct, and I think it's important to know that not only the healthcare worker should understand this, but your patient. It's an open discussion with the patient. Because most of the time our patient will be like, I get the flu every time, if you can give me the shot. So you have to make sure that you explain to them we're trying to prevent severe disease, hopefully preventing death from these infections.
Mm-hmm.
Okay.
One question
Yeah,
over
please.
there.
Did you scan the code and you answer the questions? Okay. So now we'll open the floor for the questions from the audience. Mike, please, here.
Thank you for this nice presentation, and thanks for JSK. I have two questions. My first question, as we know that RSV has two types, we want to know the vaccine from which type, A or B, this vaccine. Second question, as we know also that the premature can get bevacizumab as a preventive for RSV. Is this drugs we can use it for adults? This antibodies, monoclonal antibody, can we use it in for the adult? Because there is no antiviral for adult.
Yes, thank you. Anyone to answer?
So I can maybe address the first question. So you are right, we have two subgroups, A and B of RSV, but the antigen, that is the F protein, is conserved. So there is no difference between A and B. And in our vaccine that I demonstrated to you, the efficacy was demonstrated against A and against B. Okay, so you don't need to really I would say, to have any concern about the different efficacy. And when you see the numbers, 94.6% include A and B. 82 include A and B. So the vaccine works against both A and B.
For the second question about the antivirals and RSV in adults, I think the experience with monoclonal antibodies in adults is very limited. And I know that there is some case reports here and there, especially in transplant patients, specifically when we talk about like lung transplant, where patients presented with severe lower respiratory tract RSV infection and they were given the monoclonal antibodies. But it's really hard to tell if this is, the natural course of the disease or did the monoclonal antibody help. I recently had a case, like a fresh lung transplant patient who had RSV, and we did use the monoclonal antibodies on them. He did well, but I'm not sure if we can, draw a conclusion from that. So in short, I don't think we have enough evidence on adults, and maybe Dr. Tabi can.
Yeah, so I personally has also some experience in before I joined GSK, so because I also infectious disease and working with patients at high risk condition. So the monoclonal antibodies didn't work as a treatment. It's only for prevention. I would say anecdotal case reports, and also antivirals, ribavirin, it was limited efficacy. I know that there is an avenue of new antivirals, but what is important here is really do not let RSV reach the lungs of patients at high risk, because if they reach the lungs, then you are in a problem for patients at high risk condition, regardless of the condition. Could be an immunocompromised, could be a patient with a COPD. So this is why the vaccination is really very, very important as a prevention.
Okay, but I think when we talk about the practice in primary care, when we are confronted with these varieties of upper respiratory tract infection, viral infections, we treat all the same, symptomatic treatment. If there is any special consideration for RSV viruses, to take more concern in terms of observation of patient or additional medications or special precautions?
I can start and then I let Dr. Reed complete.
It's open for all of us.
Yeah, and also Dr. Zaitouni. So for me, what I learned, and I shared with you a personal example. So when you have a patient in a high-risk condition, like my mother with a heart failure, for me it was, if I detect RSV, it's going to be a little bit more scared. So I really need to take care in a different way because the risk of complications is higher. So what my action in the next year is to vaccinate. Okay, so now she is vaccinated. But this is the thing. So the learning is, okay, if you have a patient in a high-risk condition with RSV, maybe the likelihood of complications is higher. I don't know if you...
Dr. Reed?
I don't think there is something specific, and Dr. Zaitouni can help me as well with this, but mainly maybe if you test and it's positive for RSV, and you educate your patient about, to monitor themselves for these complications. But it's mainly taking care of their fever, their muscle pain, hydration.
Yeah, how about the antiviral?
Antiviral, they don't work very well in RSV. So if someone who's like outpatient and doing fine and got tested for RSV, we don't usually recommend antiviral. And very specific situation, as I mentioned, like lung transplant or BMT, bone marrow transplant patients, we might use it. And again, the data are not that promising about ribavirin. And of course, ribavirin has a lot of side effects, so this is why it's not kind of widely used. I'm not sure about bronchodilators and...
So RSV infected people tend to have more wheezing, even if they never had wheeze before, and that might be a clue. Unfortunately, in primary care, in general, even in our clinics, we hardly test. We only test when the person is sick enough, come to the hospital, and then they get tested. So many of you in primary care might say, but I've never seen a case of RSV. You're probably seeing it on a daily basis in winter, but you're not because testing is expensive. It's not done unless somebody is sick. So it is there, out there. It does contribute to a significant portion of respiratory illnesses. It tends to be much worse. So what I would say for a person who has a respiratory illness, if they start getting shorter breaths, then they really have to go and seek medical help.
Okay. So
that might be a sign of low respiratory.
Do you recommend the testing for high-risk patients?
For high-risk patients?
Like heart failure, COPDs, bronchial asthma, chronic kidney disease.
I think I would recommend testing. We really need to know the epidemiology. But if I had to invest money in something, I'll actually, instead of testing for 1,000 years, I'll vaccinate. The vaccine. So the vaccine is cheaper than the test, so might as well vaccinate.
Okay. The question which is usually encountered, how long is the period after the recovery from RSV the patient will be eligible to have the vaccine?
Yeah, the answer, I think, we don't know. In the clinical trials, we didn't check for RSV, prior RSV infections. So it was by chance, but it was sometimes out of season. So we really don't know. So after recovering after an infection, we don't know when you can vaccinate the patient. So this is not answered in the
In
clinic.
Shingrix, we usually wait for a couple of weeks or 2 months, and then we resume the first and second dose later on. But we don't have any evidence for this now.
We don't have the evidence. What we know is that the natural infection do not provide long-lasting immunity. This is the only thing that we know. And compared to the vaccine, it's the opposite. So the vaccine is providing immunity at least for 2 years.
Okay. In Shingrix, when we identify the elderly patients or the elderly populations, we define it by 50 years and above. But in RSV, the elderly patient defined to be 60 years and above. Why there is a kind of difference between the two infections in your trials, for example?
I can start and then I would say Dr. Zaitoun and Dr. Rin can. So the decision here to start with 60, it was based in the data that the risk of more severe RSV infections increase with age. So this is why the cutoff, the decision was to move into the 50s. But now, as it was observed with the shingles vaccine, we are moving down to 50 to 59. There is already data, and also there is data in patients plus 18, but patients at what we call at increased risk. Okay, so this is, but it was really a decision in the clinical trial to go to the patients with the high risk of a more severe infection.
I think it's just because, the immune system, and Dr. Zaitouni mentioned that during our talk, it ages. So the quantity and the quality of our immune system go down with age. And I'm not sure if we really know why 50 versus 60, but I think from observation and from the data out there, especially when we're talking about shingles, there is an observation that patients above the age of 50, especially with comorbidities, were more likely to get reactivation of the varicella-zoster virus. RSV, I think it's going to move down to the 50 in the coming years for sure, because it's kind of the same concept. So I think it's going to move down to the age of 50.
So immune senescence aging does start in late 40s. Bad news for most people in this room and online. And then we see increases in pneumococcal pneumonias and viral infections. So really 50. However, the older you get, the more severe it gets. So it's probably a cost-effectiveness issue rather than, scientifically speaking, in the 50s you start to have, problems with your immunity, but they get more pronounced as you get older. So for the dollar you spend on vaccination, obviously the return is much better the older the person is. But if you have the luxury to vaccinate, or if the patient has comorbidities, then definitely you push the age down.
Okay, thank you. Dr. Mohammed, our community, our populations has been bombarded with a lot of vaccines in the COVID era and the post-COVID era. And we are encountering the vaccine hesitancy from many populations. How do you tackle these kind of problems in your clinical practice? As a pulmonologist, with majority of your patients require a lot of vaccines, influenza, pneumococcal, Shingrix, as well as RSV.
So one thing I tell them, I took it myself. So I took most vaccines, waiting for RSV to be available in my hospital to take it. Definitely, it's observation, most patients. Now, for whatever reason, the seasonal influenza, people are much used to it for a longer time, so they're more accepting. And I think it's an opportunity to link the vaccination, and especially with these studies that, it's safe and efficacious and no increase in side effects, to give the RSV at the same setting, because people are more accepting in general. But I also counsel the patients that are very important. I took it myself. And all the myths So, in any country, in any city, you have a certain percentage of people going to have an MI or a stroke or connective tissue disease happening, whatever. So everything under the earth happened. It's all linked to COVID vaccine. So I tell them also, my neighbor's son had a car accident after being vaccinated. And they look at me and tell them, this is exactly my point.
Okay. Dr. Reem,
So I run a vaccine clinic in my practice, and I do, take care of those patients on a weekly basis. And I see that what makes the difference is when you talk to them, and educate them about the vaccine and what will happen if you don't take the vaccine.
Yeah.
So you have to use some scare into them so they can,
Okay.
be convinced. But I've been noticing lately that they are accepting of most vaccines. It's whenever you mention COVID, they're going to be like very frustrated and they don't want to do
Yes.
it. But they're usually very accepting of other vaccines in general.
I think we are now witnessing there is some kind of acceptance by the community in contrast to 10 years ago. And I believe that the thing which really surprises me in my practice as a family physician, that the parents who have been keen to vaccinate their kids and to make the vaccination for pediatrics 95% coverage, they're hesitant to take their own vaccinations for them as an adult. So that's why our adult vaccination is going all the way down below 40 and 30. So this kind of mindset has to be changed, and I think we have to make some kind of move towards enhancing our recommendations. So I think elevating the perception of people by education and holding the physicians across the spectrum of the board responsible to recommend vaccine once the encounter takes place. And then the healthcare system should promote this kind of intervention to protect the patients and the healthy people across the board of the health institutions and others. In fact, I would like to listen from our audience their experience in tackling vaccine hesitancy. Anyone? Please, question. Yes. I've got a question. Do you have anyone who would like to share with us any interventions or any solutions to tackle vaccine hesitancy in your clinics?
Including from physicians.
Yes.
I mean, not being forgetting or not giving the vaccination the importance it requires. So it really should be on the radar screen for all physicians.
Dr. Rashid, would you like to say? Yeah.
No, I like the comment of Dr. Zaitouni that somebody never had an accident after the COVID vaccine. So there is no correlation because people, even the doctors, as you said, physicians, I know physicians, they always talk about very rare 1 in 1,000 complication which has occurred with long back with some vaccination, and they say, oh, these are the complications. I said, okay, you want to wait for 10 years to know that it is safe for in long term. So, but this discussion goes on. But as Dr. Ashraf mentioned, that it is getting reduced, much reduced now. For whatever reason, now people are telling that there are sudden deaths these days. They're related to COVID vaccine. Mm-hmm. So.
Okay, thank you so much, Dr. Rashid. Anyone would like to volunteer to share his experience? Dr. Karim. Dr. Karim, you are a pediatrician. Mike, please, here.
My concern was about the routine vaccine program, which we have now, national program. It's a RSV vaccine is not included. Mm-hmm. Even in the neonates and all those things.
Yes.
When we can hope about it, I mean, when it can be introduced into that?
Yeah, I think this is a very important point that RSV is not yet included in our national immunization program. So I think this is one of the things that make the recommendation a little bit loose. And I think this is one of the things that has to be taken. Thank you so much for the comment. We have a question here. Tfadal, Doctor.
Thank you so much for this comprehensive presentation. Actually, my question regarding the According to our local recommendation here from Ministry of Health, the RSV vaccine is considered for 60 plus. How about the patient with comorbidity and they are less than 60? Is there any recommendation globally or even locally? This is the first question. The second one, also we know that from the presentation, the RSV virus is hitting children and older people. Regarding the children, we know that apart from the monoclonal immunoglobulin given to them, is there any trial for RSV vaccine for this small group of children? And the third question, what is the optimal time to give the vaccine for immunocompromised patient with, they are actually taking their medication in the same time? I mean, the optimal time. Is it advisable to give them the vaccine at any time, even during the treatment? Thank you so much.
Okay, thank you so much.
Yeah. So I can start. So I think that the first question is, okay, we have patients at risk, or what we call at increased risk, below 60, and it's true. And so in the case of GSK, we are really looking to patients, so 50 to 59, the data has been already released and included in some countries, so US, Europe, and now we are looking to patients plus 18. But those patients, as you mentioned correctly, is patients at increased risk. So at increased risk, it's patients with one condition that can increase the risk of more severe disease. Then for the immunocompromised, and I will ask Dr. Rin to reply. So developing vaccines for children, GSK at this point in time, we do not have any program. We have some preclinical initiatives, but I know that if you look into the landscape of the RSV vaccines, there is some other manufacturers that are looking to progress for vaccination in children, so beyond what you said, the monoclonal antibody.
So vaccinating immunocompromised patients, the main problem is their immune response, right? Because you don't expect them to mount the same antibody titer to vaccination when you compare them to general population. And this was proven during the COVID pandemic and was seen in those patients. So the problem is not they're not going to react in a different way. The problem is they're not going to have enough immune response to the vaccine. I think there is data coming up about the RSV vaccine in immunocompromised population, but I feel it should be safe, especially if we compare it to the Shingrix vaccine that we use in our immunocompromised patient all the time. About the timing, it depends. So if we're talking about a fresh transplant, you have to wait at least 3 months before you give them any vaccination because you want them to be stable on their immunosuppressive therapy. But for other immunocompromising condition, if they're stable on their immunosuppression, there was no changes, I would think it should be safe to administrate any vaccine, not specifically RSV.
When the patient is on variable dose, say prednisone, try to wait till prednisone less than 20 milligrams, for example. There'll be an opportunity. Somebody in rituximab or something, you try to do the vaccine just a few weeks, 2-3 weeks before the next dose. So the least immunosuppression, hopefully, give them some time, 3-4 weeks to develop some immunity. But there's no one rule for everybody.
Okay, we hope that we answer the questions. Yeah, we have another question here. Mike? Yeah.
Assalamu alaikum. My name is Abdurrahman Mahidif. I came from a home healthcare scope. So the question is related to the resistance from the community for all vaccines, including RSV. Is there any specific tools or tests to measure the need for the vaccine and to measure its efficacy? We already have a data, but if we can translate it in a simple words to our community. That's first. And the second, did we identify in the clinical trial smoking against non-smoking population or not? And thank you so much.
Thank you.
So the first question was simple rules. Well, the first rule, the older you are, the more important it is to take the vaccine, for sure. And then the presence of comorbidity. So somebody who has also the multiplicity of comorbidity. And so many older people have more than one. So if they're smokers, they might have COPD and coronary disease at the same time. And God forbid, they might have diabetes, liver disease, what have you. So the more comorbidities, the more likely this person, if they develop any respiratory infection, including RSV, they will not do as well. So this will be the main thing. Also, the older, the more frail the person is, the more likely that if they develop the respiratory infection, they will actually not do as well. So that will be the general rule. And especially for you, when being in home health, so most of your clients are actually sick enough not to go to even be transported to the, so it's probably, it applies to all of your clients in home health.
Yeah. Okay, I think home healthcare is the missing setup in our healthcare system. We always tend to promote vaccination within the organization, institutions, and even in the public area, but we never thought of getting into the home of patients, where we find the majority of our patients, they are homebound, bedridden. Many of them, they are vegetative, with multiple comorbidity, and they represent the high-risk populations that they are not getting into the consideration of receiving these kind of vaccines. So I think it's call for action that we have to consider them as high-risk patients to promote vaccinations with all the spectrum of vaccines that is required for them to save them.
And if I may also, not only your patients and the people around them.
Yes.
And also the immunocompromised patients and the people around them. So it's very important not to forget that.
Yeah.
Yep, I think you mentioned, so if you want to see data of the vaccine in the real life, that's right? Yeah. Mm-hmm. Yeah, so yes, and there is already data in the real life of the vaccines. It's effectiveness, it's preliminary effectiveness studies in the United States. They just come out and published in JAMA, I think 2 or 3 weeks ago. And the vaccine was effective in reduced hospitalization by 70 to 80%. So the vaccine works. So we show the efficacy. Efficacy is the first, is I would say, it's the most important thing to demonstrate that the vaccine works, because you are comparing to the placebo group. In the effectiveness, other things plays a role, but it's very important to show that the vaccine really demonstrates effectiveness. And regarding this question to addressing patients in nursing homes, addressing patients with difficult of mobility, so I would say go to the patient and vaccinate. For sure, it's one strategy that is working, and all over the world I see more and more countries doing this strategy, because you really increase the vaccination rates for those patients.
Okay. Any other things you would like to add?
Comments, yeah.
Any other questions? Okay, we have question here, please, Mike. Yes. Online, they send the questions through the WhatsApp. I got it, yeah.
Thank you for this informative presentation. My question about maternal RSV or RSV in pregnancy, which can give passive immunity to infants, and its availability in Saudi Arabia. Thank you.
Thank you. Good question.
What was the question?
Pregnancy, RSV in pregnancy.
Oh, you mean infection or
Vaccination.
vaccine?
Vaccination, yeah.
We all know that there is another vaccine that you can give it in pregnancy, but I think the vaccine that we're talking about today, it's not been tried or tested in pregnant ladies, so I don't think we have safety data about use of this specific vaccine in pregnant ladies. But passive immunity from mother to the newborn is a common concept that we use in practice, and the other vaccine have showed that it does help with that.
If I may add, so I think it's correct. So this vaccine is addressing only adults, adult population. So as I said, so the age is increasing. For the prevention of the disease in children, there is one strategy that is the monoclonal antibodies that is also demonstrated a very good effectiveness in reducing hospitalizations in many different countries that introduce it. So in Spain, in Chile, in France. So this is one strategy, and there is another one that Dr. Rin mentioned, that it's the maternal immunization.
Okay, thank you. Any other questions? All right, so I think we have answered all the questions from the audience online and even from all of you, and I think we are coming to the end of our session. But before we end, I would like to share with you some thoughts and some important statement that has been highlighted by our guest speakers. The first thing is Dr. Arim, she mentioned all the details about the RSV virus infections and the mood transmissions and the burden elegantly. Dr. Zaitouni, she has said the RSV exacerbate bronchial asthma and COPD and enhance the hospitalization in these patients by 7.2% for bronchial asthma and 11.4% for COPD. So this is a very alarming statement that these people at risk, we have to consider them to be vaccinated, not to get this kind of consequences of complication and ultimately hospitalization. Dr. Ottavio said viral infections in adults may lead to cardiovascular complication with all the modalities of cardiovascular, including heart failure. And one of the studies which was mentioned, 28 to 55% of the adult hospitalized with heart failure and RSV. So there is an association between the high prevalence of complications of heart failure with RSV infection. Dr. Arim elegantly said early diagnosis is very important and it's very crucial for the patient at risk. And if the infection goes from the upper to the lower, it means that damage has been made and the complication will start, and this will shoulder us with a lot of consequences in terms of interventions and the quality of life of patients and even the burden on our healthcare system. No antiviral is adequate to treat RSV. So the only solutions and the ultimate solutions and the ultimate modality of prevention is the vaccine. So again, the natural immunity after vaccination doesn't last longer. So that's why we have to focus on the vaccine, which gives a protection for almost 2 seasons, as it was said by Dr. Ottavio. And Dr. Reemshe said that the co-administrations can be done and doesn't reduce the immunogenicity of the vaccine. So feel free to combine the RSV with other vaccine that is the patient is eligible for. So with this, ladies and gentlemen, I'm sure that we have got a lot of information that will be a message, will be taken not only home, but will take it to the clinic tomorrow onwards and to be implemented in order to identify population at risk, to screen them and to diagnose them appropriately for RSV and then to treat them. And the most important part is to prevent the RSV by implementing the vaccine that we have, learn all the details regarding its efficacy and the safety. With this, I would like to thank you all for attending with us here today. On your behalf, I would like to thank our guest speaker, Dr. Arim, Dr. Mohammed Zaitouni, and Dr. Ottavio for their wonderful contribution, for the rich information that we have shared today. I would like to convey my gratitude and thanks to GSK as well as the Saudi Society for Family and Community Medicine. We have shouldered this kind of event to be part of our mission in the Saudi Society for Family and Community Medicine. Why? Because we are the gatekeeper and we are the one who defend our healthcare system by being the soldiers to have the weapons of the prevention that no other specialty has it. So please try to demonstrate and enhance your role as a family physician and a primary care to implement vaccine and to educate our patients and to be accountable to recommend vaccination for those people in need. With this, ladies and gentlemen, thank you so much. Looking forward to see you again and again in other vaccine talk shortly, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much.